so I could not get you.
Okay.
Morning, sir.
Good morning.
Good morning, Dr. Keria.
Yeah,
Hi.
Dr. Shreya Butala, you are online, ma'am. Good morning.
Yes, sir.
Yeah, good morning, everyone.
So as I was saying routinely, Dr. Harwani is always there with us, so not an issue. It's a postgraduate masterclass for Department of General Surgery, BJ Medical College. We are having a case of portal hypertension today, presented by Dr. Yash. And our expert panelist includes Dr. Prabal Niyogi, who is our president 2024 and professor at Medical College. And then we have with us Dr. Lakshman Khiria as a gastrosurgeon. Dr. Yogesh Harwani is with us. He is a DM gastroenterologist.
Sir, I take your permission to introduce Shreya, sir.
Just a minute. Just a minute. And we have Dr. Ramanaj Mukherjee, who is a professor of surgery at Arjikar Medical College, Kolkata. On our teaching side, apart from Dr. Mukherjee, we have Dr. Neena Ben, who will be joining shortly. We have Dr. Jayesh Parikh and Dr. Prashant Mehta, who are professors. Yeah, please continue, Dr. Harwani.
Shreya
Good morning,
Butala,
everybody.
sir. Good morning.
Good morning, sir. Hi.
Good morning, sir.
Ah.
And I think you have started. I'm sorry, I'm a bit late.
No, sir. We were just waiting for you. We were just waiting for you. We are just starting.
Ramanuj is also joined.
Yes, sir. Just one more minute.
So Shreya is a medical gastroenterologist, and she is young, very academic, and she has completed her DM from SGPGI Lucknow.
Great.
And she is with us, sir. She is our colleague at Noble Gastro Hospital. I am sure that she will be able to contribute.
Yeah, good morning, everyone.
Good morning. Good.
Okay, I think we can start. We have all the experts. Teachers will be joining. Dr. Ramanuj already there. Yes?
Yes, sir.
Okay. So the idea is to get the history part, the summary of the history, the examination part, the case history, and the discussion. You can interrupt the student at any place, and there are no limitation, no statute limitation to knowledge. And if you feel fine to discuss anything, please take the initiative. Yes, please start.
Good morning.
Just a minute. Are we? What the pattern is like? Let him finish the history, and should we stop him after history?
Sir, in history, if you see, routine is that he complete the history part. The history part, the short summary of the history.
Yeah.
Then we can again discuss.
Fine.
Yes, and then again, then examination and the conclusion, and then again.
Yeah,
Right,
that's
sir?
fine. That's fine.
But in between, if you feel like that something is important, you are free to interrupt at any given times. All the inputs are always welcome, sir.
Shall I start, sir?
Yeah, start.
Good morning, respected teachers and my colleagues. Today I'm going to present a case on portal hypertension. Myself, Dr. Yash Patel, third year surgical resident in Department of General Surgery in BJ Medical College. I'm presenting the case under guidance of my PG teacher, Dr. Nina M. Shah, Dr. Pankaj Modi sir, Dr. Apurva Shah sir, and Dr. Hirsi Chauhan, my assistant professor. 47-year-old female from Vadnagar, working as a housekeeper, present belonging to a middle socioeconomic class, presented to civil hospital in emergency with the chief complaint of hematemesis for 6 hours, 4 bouts of hematemesis. Coming to origin, duration, and progress, patient was apparently asymptomatic before 11 years. Then developed pain in the left upper quadrant, which was insidious, dull, aching, intermittent, non-radiating, and self-limiting pain without associated with the lump in the left upper quadrant. It was initially smaller in size, and which was gradually progressed to become larger. History of weakness and lethargy is present. Patient had episode of melena 7 days back, and she developed 4 bouts of sudden onset of painless, diffuse, non-projectile hematemesis containing fresh red blood without blood clots and not associated with the retching or nausea.
Yash, have you kept one another laptop or mobile on Zoom?
No, ma'am.
Because there is some voice in between. Okay.
There is no history of jaundice, fever, dyspnea, oliguria, breathlessness, weight loss, joint pain, and past history. Past history of blood transfusion in 2009, 1 unit PCV for anemia. History of upper GI scopy in August 2018. At that time, patient was diagnosed to have large esophageal varices, 3 column without any red color signs, and stomach shows there is edematous mucosine fundus and gastroesophageal varices type 2 without any red color sign. In the body part, edematous, and at that time patient was advised esophageal variceal ligation, but patient refused, and after 1 year patient again underwent the UGI scopy, and at that time variceal ligation was done. Patient was on some medication after upper GI scopy, which he took for 2 years and then stopped. Past history of cesarean section in 2010 and laparoscopic TL tubal ligation in 2000. No other significant past medical or this other surgical history. Coming to personal history, patient is a vegetarian with unaltered appetite and sleep pattern. Patient had, apart from the history of melena 7 days back, bowel habits are unaltered and bladder habits are unaltered. No history of any addiction or any drug allergy. In OBS guiding history, patient is having gravida 2, para 2, no abortion, and 2 live birth. First male child born with the cesarean section, and second female child born by the normal vaginal delivery at full term. Menstrual cycles are regular, and last menstrual period was 25th November. Coming to family history, patient is having 5 siblings, and patient is firstborn child, and all the deliveries are institutional without any postnatal complication. History summary: 47-year-old painless hematemesis with a lump in the left upper quadrant, with past history of upper GI scopy for the esophageal varices and recent history of melena. History of blood transfusion once. patient is non-alcoholic and non-smoker.
Go to first slide.
Okay, and second slide. Okay, Dr. Ramanuj.
Yes, very good morning. Yes,
Good
it
morning,
was a
sir.
good presentation, but there are few things to say about. Now, number one is that whenever you are mentioning an history and you are making a slide, it is hello.
Hello.
Right. Now,
Yes,
it
yes,
is
sir.
requested that please mention your write up in a point rather than write in a paragraph because it becomes everyone to understand. Now, so as you have said, this is a middle-aged lady who presented with a lump abdomen, and then thereafter he presented with an episode of a GI bleed. Number one. Number two is that again some examiners will be objecting to the word of melena, hematemesis, esophageal varices in the history of the present illness, which is expected to be as narrated by the patient. So it would have been better if you had said it was a black tarry stool. Now, doctor, so as you have said that this patient presented with a history of a lump and then followed by the history of a GI bleed. Now, what exactly is the system that you are trying to think in your mind before you go to the examination?
Sir,
I have a point before that.
Yes, sir. Yes, sir.
When you are starting, can you get your first slide, please? Right. I would prefer that when you put this, you first put the patient details, that this is a 47-year-old female from working this. The second should be the presenting complaints. So that has to be mentioned. This patient is presenting with a 6-hour history of hematemesis. So that is where your history starts from, isn't it? So in your next slide, coming to your next slide, now you have said that patient was asymptomatic 11 years back. Now, usually a history of present illness starts from that point when you are saying history. The rest of that comes in the past history. You get my point?
yes, sir.
So either all this comes in your past history, right? Because your episode is only for 6 hours, and then you can describe what happened after that. And that is, or you can say that this is a patient. The history is there of a lump which was there for the last 11 years. You can start from there, and then you can come to the history of illness. So, what do the other examiners think about it?
Definitely, sir. Sir, I think that is the usual standard pattern that the examiner will like to hear. And that is the thing that you should always follow, as Professor Probal Yogi said. So you have to please rearrange your history in that style. That becomes easier for you to narrate. And the examiner is making the mental picture of the patient as the patient was from 11 years to this present date. So he is tracing the patient as you are. So I think that is a better way of representing.
But we do consider the 11 years as the same history. So in the history itself, he could have said that it's a known case of maybe portal hypertension with chief complaint of hematemesis for the present. Because what we have been teaching or what I have been taught the way is that the whole thing is a single history and it is just one more episode of the same complaint.
Exactly, sir. That is what I was saying.
Yes.
So he could have started his history from 10 years. Like this lady has had a lump in the abdomen for the last 11 years, and then take it from there, and then has repeated episodes of bleeding, upper GI bleeding, or black tarry stools. Could have been done that way also. Anyway, that's another way of doing it.
So yes, it should be a lump in abdomen for 11 years and at present this thing. And he has, and your origin duration progress again, because he is having this lump since 11 years and already had 2 histories of hematemesis. So it's a continuous history.
Yes, I would do it that way. Yeah.
Also, the melena should be like it should be mentioned that she's been having melena for the 7 days in the presenting complaint only. So the abdominal lump for 11 years, melena for 7 days, and active hematomasis that should be mentioned in the presenting complaints. If you start the origin, duration, progress from the 11 years, then.
Jayesh bhai, Neena ma'am.
Yes, whatever you said, we are doing like this nowadays, and so for few diseases we start like this. Routinely we do not do like this. As Prabal, Yogi and Ramanuj say, we routinely say same thing in all the cases. But for portal hypertension or some patient who is having splenomegaly, in this we change history like this in our institute particularly. Right.
So I agree with that. If patient was asymptomatic before 11 years, then in ODP he must started up to the 10 years of the narrations.
So I think we can write that the complaint was of lump in abdomen, and he came with history of melena for 7 days and hematemesis for 1 day.
Right.
And then in the origin, duration, progress, right from the day 1 of development of lump with hematemesis and melena in between.
Hello, can you
Yes,
hear me?
yes, sir, please. Dr. Khiria.
Normally, what we do in a specialty, because majority of patients have a longer histories rather than a short history or initial presentation, we call it as a problem-oriented medical record. Right? So
Right.
somebody complains, suppose, of dysphagia. So you start, this patient had dysphagia in 2010. Then relevant history is like that, okay, consumed acid, they developed stricture, subsequent management will be included in that problem-oriented report. Because that particular problem for which patient came, so we call it a POMR. And this is how normally in most of the patients we narrate that. So portal hypertension is like a chronic condition which requires longer treatment. So you start with the date of initiation, the first date, say around 11 years ago, that patient diagnosed with the lump. Then subsequent symptoms were keep on developing, patient was under follow-up or not, but taking treatment or not. But current situation, 6 hours ago, that patient presented with hematemesis. So the background is clear that this patient is a known case of portal hypertension who is receiving treatment or under follow-up. And now the current status is this.
Okay.
I hope that is a
Yeah.
good presentation. You can move ahead.
Yeah.
Can you
Continue.
show the negative history slide?
Yes, ma'am.
Yeah, so one important thing you should mention in this is the history of abdominal distension or the ascites. So which you have not mentioned over here, because in the differential diagnosis of portal hypertension, the history of ascites is very important in differentiating the cause of portal hypertension, as well as the altered sensorium.
Yes, ma'am.
Go ahead.
One thing I would like to mention, he has mentioned the upper GI scopy finding.
Yes, sir.
In MS examination, he had no case records. If patient is intelligent enough, he tell ke banding or something done, you can tell it. Other under some endoscopy was performed.
Yes, sir.
Prashant, your inputs? Prashant, he's there. I don't know.
I agree with Dr. Jayesh, because you could have only said this is the history, what we're taking for the patient. So I don't
Yes.
think you'd have to need to give records. Like you just she
Right.
has a given history of endoscopy in 80. That's all.
Yeah.
Something was done. Some
Yes,
procedure
something was
you
done.
know.
Yes, yes.
Yeah.
I agree, sir. I agree. Right. Okay. Continue. Anything from here, Dr. Niyogi?
Appetite unaltered, sleep unaltered. What is sleep unaltered? What does that mean? Can you be more specific about that?
Yes, sir. No daytime sleepiness and the decreased nighttime sleep pattern, sir. patient.
What are you looking for? The first, what are you asking in sleep pattern? Like, what is important from your point of view, knowing that there's a lump in the left hypochondrium and hematemesis and melena?
So it indicates the early stage of hepatic encephalopathy. The altered sleep pattern is the earliest sign which could prompt suggestion.
Yeah. So there's reversal of sleep pattern. That is one. There is what grade of encephalopathy is that?
Sir?
What grade of encephalopathy is that? Or altered sleep pattern?
The grade 1 is altered sleep pattern, sir. With
Is
decrease.
the grade 0 also?
Yes, sir.
What is that?
So in grade 0, so patient present with slight agitation and decreased attention associated with the altered sleep pattern, sir.
Yeah. Okay. Right. Fine. And bowel melena, again, as Ramanujan rightly said, so it's basically it's black tarry stools rather than melena. That should be placed. And what exactly? How do you compare a black tarry stool? What is a black tarry stool?
So passage of black colored stool.
Have you seen a?
No,
have
no.
you seen
Sorry is asking what is black tarry. When you say black tarry stool, what do you mean?
So black colored sticky stools per rectum passage of it indicates sir upper GI bleed source is more.
No, that's fine. What does it resemble? Have you seen a melena stool?
Yes, a tar.
Coal tar. That's why it's tarry, isn't it? It's like coal tar, like it's liquid tar when you put on the roads, right? That sort of a consistency is there. And why did you ask for bladder unaltered? What are you this thing thinking of?
Sir,
why do you take that history?
Decreased urine output in cases of due to severe hypotension and hepatorenal syndrome, which is a complication of.
So that you would have mentioned, like unaltered bladder unaltered doesn't make sense, does it?
Yes, sir.
Unaltered bladder doesn't make sense. What are the signs of urinary symptoms that you take in history? What are the irritative symptoms? And what are the obstructive symptoms? Can you name some?
Yes, sir. Irritative symptoms are frequency and nocturia, and the.
That's all.
Obstructive.
No, though there's only two you said: frequency and nocturia.
Okay,
okay, carry on. Go ahead.
Okay.
No, not this. I'm asking you about the. See, I have to. Whenever in an MS exam, we all know that you have come prepared with portal hypertension, melena, hematemesis, right? Always the examiner takes you slightly off passage to know how much you know. So we assess in that way. So I know you have read portal hypertension. You must be a master of portal hypertension. You will be knowing more than what I know in portal hypertension today. But that is the thing. We would like to examine you also on side things. Like I'm asking you, what are the irritative symptoms of urinary and what are the obstructive urinary symptoms?
So obstructive
enumerate them.
Obstructive symptoms are decreased stream, narrow stream, intermittency, and sir, incomplete evacuation, sense of feeling after the passage of urine.
Okay, so I'll tell you the irritative symptoms. You only mentioned two, that frequency and nocturia. You have frequency, urgency, nocturia, and dysuria. They are the four irritative symptoms. Whereas the obstructive symptoms are hesitancy, intermittency, dribbling, incomplete evacuation, and poor stream. There are five. It's very clear. There are four irritative symptoms, then there are five obstructive symptoms. It's just out of the text, of course, out of context, but that is just to make the students aware that we examine slightly away from your topic. Right. So now next one is history of addiction and drug allergy. What are you thinking of and what are you asking for?
Sir, in history of addiction, the alcohol in
like alcohol, yes, fine. Okay, what else?
Smoking. History of other medications for like contraceptives, which increases the growth history of any Ayurvedic treatment, history of addiction to analgesic. The
common medicine used in our country for a common disease which has got relevance.
Yes,
Could you name that?
Peptic ulcer disease, the bleeding can be due to the
No, I'm talking about drugs.
Sorry, sir.
Basically, I wanted to know what history will you take, drug history, in a case of such a case that you have got here.
Yes, history of any.
What have you taken? Drug nika liya hai? Or
Sir, past history of blood thinners, whether patient was put on blood thinners for the previous thrombotic event, or history of other non-selective beta blockers for the prophylaxis of variceal bleeding in this case.
right. So she is not on any drugs then. But you said that she was on drugs for some time.
Yes, sir. She was on drugs after the UGSCOPy for 2 years. But she
What are the common drugs that cause liver problems?
Sir, the NSAIDs, the analgesics.
NSAIDs, okay. NSAIDs, does it cause more of liver problem or does it cause something else?
Sir, more of urinary renal function alteration, but sir, it can in case of cirrhosis, when the patient is having
what is renal function alteration? See, you are giving an MS exam. You have to be very specific in what you say. Even this will hold good even after your MS when you're talking to a patient. Please do not use loose words.
Yes, sir.
I'm asking you a very clear question.
Sir, increase creatinine and decrease excretory function in renal function test.
Okay, fine. Carry on. Anybody else? Any other example?
Yes, in this point, yes. Now, number one is that apart from alcohol and apart from any other drugs, any other habits or any other personal habits or addictions that are very important in cirrhosis of liver that you must obtain, like you have taken blood transfusion, any other habits that you should emphasize?
Sir, the uncommon like bush tea consumption or consumption of other Ayurvedic drugs, sir.
More common will be an intravenous drug abuse.
Yes.
Particularly, remember, hepatitis B and hepatitis C will be transmitted through sharing of needles. So
Yes.
that needs to be taken care, number one. Number two, whenever you are talking about, now this lady does not consume alcohol, okay, that's a different scenario. But maybe that in an examination, you will be getting a gentleman or a lady who has consumed alcohol, and you are dealing with an alcohol-induced cirrhosis. Now tell me, if this is the prototype case and we have all the residents listening, if the patient is consuming alcohol, what are the questions that you would like to take from that patient regarding addiction?
Sir, the since how long she is taking the alcohol, the amount of alcohol and the frequency of alcohol and type of alcohol, sir. Whether she is taking the alcohol made in the village type, like containing the poorly preserved alcohol, and along with the alcohol, the history of binge alcohol intake and the last consumption of alcohols.
Okay, apart from that, next is, so as you have very rightly said, this should be the points that you should emphasize. To summarize, the amount of alcohol, particularly in grams per day, if you know the type of alcohol. Number three is, as you have said, it can be adulterated like country liquor, and the duration of the consumption of alcohol. But there is also another important point, whether the patient is still addicted to alcohol or whether the patient has any tendency for any craving of alcohol. Do you know of any questionnaire that is something that we do to assess the alcohol dependence?
Sir, physical dependence symptoms like patient needs alcohol, whether in the early morning, which is severe
Do you
alcoholism.
know of any questionnaire or any mnemonic that is asked in an examination or in a patient history to guess whether the patient is still addicted to alcohol? Because your treatment during the phase of the management, you may need even a de-addiction therapy, because the treatments will be very, very modified if you are having a patient who still consumes alcohol. Do you know of any questionnaire that is done?
Sir, I was aware, but I don't remember right now.
Okay, no issue. that is called as a CAGE questionnaire, CAGE. Okay,
Yes.
the CAGE stands for the patient will be asked about the amount of the alcohol, and it is technically it is called the cut, annoyed, guilty, and I. So they were usually the words that were done, but it is technically called as a CAGE questionnaire that was used to assess that. And some examiners will ask you whether you have known whether the patient has still any tendency for consuming alcohol. Apart from that, all the things that you have said, particularly regarding this patient, is extremely important about this case. The next is that, as you have said about this, the patient underwent a surgical intervention, cesarean section. Now, what are the viral diseases of importance in this case that are transmitted by a surgical intervention?
Sir, hepatitis B, hepatitis C, and sir, HIV virus.
Okay, very good. So that remember that, but please remember, always tell that it was done maybe in a tertiary care hospital which had proper precautions regarding sterilization and perioperative. Okay, so that's all my part.
So when was this cesarean done? Which year was it? Because
Sir,
is it before preceding your history of 11 years or is after this? That's
yes.
important. You have to mention when this was done.
Yes.
When was it?
Sir, cesarean done 14 years back.
So it was before she started with this problem.
Yes, before.
So that is also important in our history, the timing for this. Right. Go to the next slide.
Yes, my one question, how the cesarean section can give rise to development of portal hypertension?
So, during cesarean section, the post-operative complications like pelvic abscess or collection or secondary peritonitis, which can lead to portal pyemia. And secondary to portal pyemia, patient can have the thrombosis in portal vein.
Okay, continue.
Hello.
Yes.
What is the history of immunization?
I did not ask.
History of regarding the immunization regarding the hepatitis B vaccine? History?
Sir, patient
Like
taken any? Sir, I had not asked, sir, about that particular question, sir.
Okay.
Your portal pyemia is a bit of a long shot. Now, I've never heard a portal pyemia leading to portal hypertension.
Absolutely, sir.
It is absolutely not. What does portal pyemia lead to?
An abscess formation or maybe sepsis, but
Exactly, abscess or a sepsis form. Sepsis. It will never lead to portal hypertension in any way. That was probably not a thing. As Madam asked you, what are you looking in? What terms? Cesarean section. Why is that important in the history?
Intra-op or the post-op operative complications. If after the surgery patient was immobilized for a prolonged period, so there could be history of any deep venous thrombosis.
What is another thing in pregnancy? What happens in pregnancy, which can cause some liver problems?
Hypercoagulable state, pregnancy.
Exactly.
Itself.
So what condition are we thinking of?
Sir, increase.
Think of the post-hepatic causes.
Yes, sir. Budd-Chiari syndrome.
Yeah, Budd-Chiari, isn't it? So that is the relation. If you actually want to extrapolate why she had a cesarean and how to connect the two, you can say that instead of saying portal pyemia, right? So that was my point. Okay, go ahead.
Second thing is postpartum hemorrhage. Missed. The patient has developed postpartum hemorrhage or not. It is a sign of a low platelet count, and disease might be existing.
Sir, no history of postpartum hemorrhage, sir.
Okay.
Actually, sir, this cesarean precedes a history of 11 years. So this is before 14 years, he said, I think.
Yes.
So this
Right,
is
sir.
before one.
Right.
Right. Okay.
Continue.
Go ahead.
Also,
Next
in the
slide.
family history, I mean, you have mentioned that there are 5 siblings, but you have not mentioned whether they have any. What is the significance of the family history in this scenario?
The family history of any hematological conditions and the history of jaundice, the familial
What
jaundice,
pathological conditions you are thinking about?
Wilson disease, and the other hemolytic anemias, thalassemia, for the splenomegaly. And
You have not mentioned anything. You have just mentioned there are 5 siblings.
yes.
So what other family history would you like to know about?
I mean, family history, history of jaundice, history of blood transfusion, history of
So
malaria,
which are the diseases you would expect to rule out in the family history?
certain hematological conditions like hereditary spherocytosis, hereditary elliptocytosis.
So have you
The
seen hereditary spherocytosis presenting with hematomasis?
no, to rule out for the differentiating splenomegaly.
Okay, but I mean, are there any diseases, inherited causes of portal hypertension, which can be seen in the family?
Inherited causes like I'm not aware about the family.
Ma'am, please elaborate.
Yeah.
Yeah, so the things like you can have a family history of Wilson's disease. Another is important is the hepatitis B, because HBV cirrhosis can be there in the other siblings or in the like also in the parents. So it is transmitted from mother to child. Transmission of hepatitis B is also there. So you need to specify whether there is any history of cirrhosis or similar complaints in the siblings, right?
Okay, continue.
So the history summary.
So fine. So, sir, can we go ahead with the examination part?
Sir, I would like to stop here.
Yes,
With
yes, sir,
this
please.
history, what comes in your mind and what do you think would be the probable diagnosis with this history?
Sir, acute variceal bleeding secondary to portal hypertension with splenomegaly.
Oh, well, portal hypertension, we can say that is portal hypertension. What you're thinking more than that? What else can it be?
Without.
What are you looking at? What pathology in which organ?
Sir, extrahepatic portal hypertension, most probably, sir.
So you think it's an extrahepatic portal hypertension you're dealing with, right? So from your just the idea, what are you thinking of? It's an extrahepatic portal hypertension you're thinking of. Why do you say that?
Sir, patient is not having a past history
Only
of,
by history, right? No examination done as yet.
because sir, patient was previously underwent upper GI scopy and diagnosed with the esophageal varices. So this episode of hematemesis is most likely due to portal hypertension, sir. And at that time,
Okay, so fine. So you think of extrahepatic portal vein obstruction in this. What is the common age of presentation of extrahepatic portal vein obstruction?
sir, third to fourth decade, sir.
It's early, isn't it? Much
First
earlier.
and second defect.
First and second decade, exactly. Adam is absolutely right. The first and second decade of life that you get extrahepatic portal vein obstruction. So from your history, you think it's extrahepatic portal vein obstruction, which I don't agree with. What else can it be?
The non-cirrhotic portal fibrosis.
Non-cirrhotic portal fibrosis. What is the common age group? You don't have any other finding. You just have the findings of history. From this, I want to make you think what can be the causes of this. So
Sir,
you
it's
think
asking about in the pre-hepatic or post-hepatic, whether it's pre-hepatic or post-hepatic from your history.
From the history, sir, it is more likely to pre-hepatic, sir.
Pre-hepatic. So pre-hepatic could be either extrahepatic portal vein obstruction, which could be ruled out because it's 47 years old. It's not the right time for that. And the other diagnosis could be an extrahepatic portal, NCPF, non-cirrhotic portal fibrosis. Right. So we'll take it from there. Now let us go to the examination.
Sir, I think one comment to be made as yes, see, understand Professor Pradal Nyogi's question. He asked you what are the things that you will think of. Now, if I am the candidate, I would have answered, sir, that I am thinking of a patient with an upper GI bleed with an probable splenomegaly, and I will like to take a history. And in the examination, I will like to now go in a preference for abdomen examination with a thought for a portal hypertension. This makes your answer very wide
Yes.
and your answer open for discussion. Remember that there are examiners, as I have said, as Professor Nyogi has always said, that you are now the master of portal hypertension, but the examiner will like to deviate away from portal hypertension, maybe. So remember that the examiner may take you now to a benign peptic ulcer disease in a real examination. So please open an avenue always for a discussion. Maybe the patient with a splenomegaly which has not produced a portal hypertension yet. So always be with an open mind, keep an open area for a discussion, and then gradually, when you complete the examination, you will have points which will support your diagnosis of a portal hypertension. Okay, so I think please proceed with the examination now.
Summary history is, sorry, just spelling of summary is wrong. Go ahead.
Yes, the point is, this is a learning process for almost everybody. Dr. Ramanuj Mukherjee's words to the point are excellent, and you need to understand how the examination occurs. See, basically, the examiners are never in a mood to ask one particular question. It is how you answer that we create questions. So that you need to understand. Continue with the examination part.
Sir, I have examined the patient in proper light and exposure with informed consent in the presence of female attendant. Patient is conscious, cooperative, and oriented to time, place, and person. Fairly built and nourished, and there is a conjunctival pallor present. No evidence of icterus, clubbing, cyanosis, or pedal edema or generalized lymphadenopathy. No evidence of petechia, palmar edema, or spider nevi. Patient is afebrile with pulse of 100 beats per minute with blood pressure of 106/64 millimeter mercury, and with respiratory system and cardiovascular system and CNS, central nervous system, normal. On local examination, on inspection, umbilicus is central, inverted. Abdomen, there is fullness present in the bilateral flank with left paramedian scar of previous fusion section, which is healthy, and a small transverse infraumbilical scar of previous lap TL is present. Stria gravidarum present, dilated tortuous vein seen in the epigastric region, with the external genitalia, hernial sites, back and spines normal.
Can you put up the picture?
Yes.
Okay, continue.
On palpation, local temperature is normal. Patient per abdomen is soft, non-tender, no guarding, no rigidity. A well-defined lump of 12 by 11 centimeter present in the left hypochondriac region, left lumbar, and the umbilical region, which is firm in consistency, smooth regular surface, well-defined inferior border, and palpable notch, which moves craniocaudally with respiration, and the fingers could not be insinuated between the lump and the left costal margin. There is dilated tortuous vein. On palpation, they are soft and compressible, and on emptying, it fits slowly from below upwards direction, and liver is not palpable. On percussion, liver span is from 5th intercostal space in midclavicular line to the right subcostal margin. Splenic dullness is present superiorly till 7th intercostal space, and there is horseshoe shaped dullness and the shifting dullness present. Normal bowel sound heard, and no audible venous hum over the dilated veins, and digital rectal examination is normal.
Hello.
Yes, sir.
Can you go to the first inspection slide? Inspection.
No, no. Prashant, general examination चालू करें ना?
Okay. Can you examination?
Please.
I heard one question. When there is a pallor presence, why did you look for the cyanosis? Is it possible pallor and cyanosis coexist?
Sir, if in mild anemia, Conjunctival failure with the peripheral sinuses could be present in connective tissue disorder like Raynaud's phenomena, but it
I
is
have
rare.
I have a question in your first slide. What is fairly built and nourished?
Build is the stature of the patient, and the nourishment applies to the muscle and the habitus. If there is
Okay, so built is the skeletal build of the patient, and nourishment is the nutritional build. How do you assess this thing?
sir, skin fold.
Nourishment.
Hello.
How do you assess nourishment?
Sir, nourishment by looking at the pallor, if patient is anemic or not, patient is having any pedal edema or ascites with increased fat with reduced muscle mass, like
How do you assess the nutritional status of a patient?
sir, skin fold thickness at the in mid-arm circumference, then
Okay.
blood basal BMI can be indicator.
Okay. What else? So there are some anthropometric measurements of this thing. Any other types of measurements that you know of to measure nutritional status of a patient?
Sir's question is, you are all the skin fold thickness and everything requires some instruments. Can clinical assessment for the nutrition?
With simple measure type and vernier caliper.
Okay, no, this is anthropometric is fine. Any other method of nutritional assessment? Generally, not clinical in any way. How do you assess nutrition? That's what my question is. Basically, how do you assess nutritional status of a patient? You have said the anthropometric measurements. You're right in that. Any other way of assessing nutrition in a patient?
Sir, by
Any blood tests?
yes, sir. The blood hemoglobin, protein, and albumin, which are the good indicator of nourishment.
Hemoglobin is never an assessment of nutritional status, right? It is not an that is wrong.
Micronutrient.
The assessment is, you're right, it is serum albumin. Apart from serum albumin, are there any other markers for nutritional status?
Sir, micronutrients can be checked.
No, they are very specific markers for nutrition. If you know the answer, say no, I know it. If you don't know, say I don't know. That is the first basic thing in an examination. Right? So you don't know. So say I don't know. That's the best way to go to the next question. Isn't it? Right. Serum transferrin and retinol binding protein. So these are the three markers for nutritional status. Okay, coming to your next. What is your next slide? Can you go to your next slide now? Palmer erythema, spider nevi, petechiae. What are these?
These are the signs of chronic liver disease.
Why do you get these signs in chronic liver disease, specifically Palmer erythema and spider nevi?
Sir, increased estrogen due to decreased metabolism in liver. Sir.
What is the site of that you look for of spider nevi?
So spider nevi on the torso and the flexion aspects, and the petechiae over the skin folds and the dependent portions.
So would you look for spider nevi over the abdomen and the thighs?
Yes, sir. Over the thighs.
You would. Spider nevi is only seen in the distribution area of the SVC, of the superior vena cava. So you can only see that in the upper trunk and the upper arms, the shoulder. That is all. You will not see it on the abdomen. And what does a spider nevi look like? Since you have said no evidence of spider nevi, I'm just asking you, where do you look for spider nevi and how does it look like?
It looks like a central small feeding vessel with surrounding small artery also.
So what instrument do you need to see a spinal MRI properly?
Sir, torch.
I expect to see it in proper light. You've already said it. You've examined the patient in proper light. So I don't think that you need another torch for that. You need a hand lens, isn't it? So you just a hand lens, simple hand lens will do. Then you can see the central arteriole and the vessels which are going by. Right. And why do you look for petechiae? Why have you looked for petechiae?
Particularly are the small pinpoint hemorrhages measuring less than 3 mm.
Are they seen in any liver condition? Petechiae?
Sir, in advanced stage of liver disease, to decrease platelet counts and increase bleeding.
Decrease platelet count. Will the platelet count go down
It's
in
a platelet count or something else? It is not related with platelet count.
How can the platelet count be reduced in a case of portal hypertension? You see, you are giving answers, so I will ask you questions according to what answer you give. So can you tell me any
Which
condition why
altered liver function will give rise to bleeding?
Altered INR.
So madam has asked you, can the platelet count actually be reduced in a patient with portal hypertension in your case? And what could be the reason for that?
The hypersplenism.
Yes, good.
Yes.
Hypersplenism could be the very good. Next
But
slide.
we will see for PT and not the INR. PT is more important in liver function test, right? Okay.
Next slide.
You said that there is no evidence of icterus. So how you measure the icterus? Where you have seen and how you elaborated it? Icterus.
Sir, in the lower palpebral conjunctiva and sclera, sir, in the dark colored room, I will check for the icterus with the light. But due to paler.
Which other sites you will see for icterus?
Sir, palms and mucosal membranes, oral cavity.
At what bilirubin you will see the icterus?
More than 2 milligram per deciliter.
Okay, very good.
So you have, this patient has got pallor. Suppose you have pallor and icterus both. So where would you look for pallor?
Sir, for the pallor, I will look for the nails and the palms, sir. If there is mild icterus with pallor, sir.
Palmar creases you can see for pallor. Right, okay. Next slide. Okay. I think next.
Do you think the CNS examination is important in this case? Do you have to mention like specific things in this case?
Right.
Sorry, ma'am.
Do you think CNS examination you need to mention certain things in the CNS examination?
In CNS examination, I will grossly the patient was conscious, and so in I was not examine. I had not examined in detail, but yes, if patient is drowsy, we can check for the motor and the sensory system.
Even in the conscious like person. How do you classify hepatic encephalopathy?
Hepatic encephalopathy is graded into 4 grades. By the first grade 1 is the decrease attention span, and the digital obstruction is altered. In grade 2, patient is slightly lethargic but respond well. And grade 3, patient is focused but respond to stimuli with the altered behavior changes. And in grade 4, patient is comatose and doesn't respond to stimuli.
So in which stage do you get liver flapping tremors?
Stage 3, ma'am.
It's the stage 2, and you need to mention that at least in your history in the CNS examination, because bleed can obviously can precipitate into hepatic encephalopathy. So you need to at least mention that in your examination that there are no hepatic flaps or liver flapping tremors, even if it's a surgical examination.
Yes, I agree. Next.
Yes, I think, sir, a few points, Yash, that
Yes,
needs
sir.
to be. To begin with, Yash, remember that this is a patient where general survey and general examination are two different terms. Remember that. Number one, in general survey, there are many things that examiners will like to see that must be present. To begin with, you have, please go to the previous slide, please. Yes. Now, number one, as Professor Yogi has said, that is very important that you comment upon the body mass index and measurement of anthropometric parameters of nutrition. Number one. Number two, as Madam has said, remember that this is a patient, the whole only patient in your whole, maybe the syllabus, where you are required to do something called mental status examination. Are you aware of any questionnaire that is required to assess the mental status of this examination or for this patient?
Sir, the pattern of sleep.
Number one
No,
is
no, mental questionnaire, sir, is asking.
examination. Doctor, we are
Like
not
the cage assessment.
How do you assess the mental status? Madam has been asking you, this is very important in this patient. Have you heard about something called as the Glasgow Coma Scale?
Yes, sir.
Yes. So you should have mentioned that. Number one. Number two, called as a mini mental status examination.
Yes, sir. I had heard. Yes.
Very good. So please mention that I have heard, and I will like to do that. Now, very quickly, can you tell me what are the four basic components of telling you that the patient is oriented in time, place, and person, or has a normal mental orientation? This is very important in this case.
Yes. So, sir, I will ask the patient where she is and whether what time around the evening or the morning or the afternoon is it.
Okay. Next. Sir, I will now see time is very precious. Please remember the 4 points. Number one, this is general survey. Tell to the examiner, I have assessed the patient according to 4 points. The appearance of the patient may be relating to personal hygiene, clothing, and other signs like tattoos, etc. The behavior of the patient during your examination, which includes the rapport of the patient, the eye contact, the body language of the patient, the psychomotor activities. Third is speech of the patient, which is very important. And the fourth point is the mood and the effect of the patient, like how are you feeling? Are you feeling depressed? Are you feeling anxiety? So please remember, these are the next important point. The next thing that everyone is asking, Professor Niyogi asked you very, very important question about this spider nevi. That is the point, because he is wanting to see something called stigmata of liver disease, which is to be described from the head to the foot. Can you please tell me what are the stigmata of a liver disease?
Sir, alopecia, then parotid swelling, the spider nevi, palmar erythema, gynecomastia in case of male, hepatic fetal foul smelling smell from the respiration, then tremor and decreased gonadal in case of male testicular atrophy. Uterine contracture, sir.
Okay, so after that, you should have again now commented upon the rest of the signs as you have mentioned.
Exactly.
Okay, then, okay.
That in one sentence you could have covered all this, and you could have given an examiner. You could have got a question from the examiner. So you've said no stigmata of chronic liver disease, so you get a question from the examiner, and you can answer it very well. So that is a way of answering exam. Right? So we are, apart from that, we are also teaching you how to present. Right? Can you come to the next slide? Okay, fine. We've done a general examination because we're running out of time, so we can go to the next one. Now, inspection, you've shown a picture. Can you show the picture? Is
PRM sir has joined. PRM sir, your inputs.
Good morning. Sorry to be late.
Sir,
Ramanand
good morning.
sir, Prabal sir, thank you. Thank you. Please
Good morning.
continue. Sorry to be late. I had some personal commitment. Sorry.
issue.
It's okay, sir. Please continue.
Yes, to the candidate. Now, your inspection, is it done from where have you seen this patient?
Sir,
See, you cannot, with this inspection finding, you cannot make out the right inspectory finding. Where, from which side, which angle should we have seen this patient? Because there is a patient has been complaining of a swelling in the left upper abdomen. Is that the right picture that you have taken? How do you do the inspection? From what?
from on this right side of the patient, standing on the right side, and on the from the foot end.
At the eye level of the eye. So only then can you exactly say that if there is any lump or if there is anything in the abdomen, right? And if the movement with respiration and all. So you have to examine the patient at the eye level. With this one, I'm sure with such a history, there would be definitely a swelling in the left hypochondria. Can you go to your inspectory finding? So you've said abdomen fullness present in bilateral flank. So is it equal on both sides?
Sir, it is slightly more over the left side, sir.
So you have to mention, even from the top view, which is not the correct view, I think there is a bit of a swelling on the left hypochondrium, if you can appreciate. So all these small things are important. Okay, come back to your slide. Okay, what is stria gravidarum?
Sir, stretch marks in the lower abdomen due to previous
During? Stria, what is the difference between stria gravidarum, stria nigricans?
Stria nigricans is the black colored pigmented stria. So gravidarum are due to stretching of skin due to increase in the abdominal pressure and
Commonest cause of stria gravidarum.
pregnancy.
What are
Sudden
the
weight,
other causes? What are the other causes?
sudden weight loss. Ascites. Ascites.
Okay. Go to the next slide. Okay. Anybody else wants to ask any inspectory? Anything?
No, absolutely not.
Go ahead.
No, please.
Now, in this slide, I would have been happy if you had just said that instead of describing the left lump in the hypochondrium, whether your fingers can be insinuated, whether you can feel a notch, you would easily say, simply said, in an MS examination. You are giving an MS examination, not an undergraduate examination. You can just say that it is a splenomegaly is present and what is the size of the spleen. You can say that, isn't it? How, Sir Pankaj, sir?
Yes, actually, let me be very clear. I already told him that you start at a spleen, but I think he was more on that. I should describe lump. I said that in MS, it should start at it's a spleen which is palpable and describe the features of spleen. I absolutely agree for PGs that it should be described as a spleen. This is no surprise or something to be disclosed at the end of the suspense.
If he says it is a spleen, then the examiner gets to ask a question. Why
Yeah.
lump is and the answers for that. Right.
What is the cause of guarding and rigidity in portal hypertension? You say there is no guarding and rigidity. What you are looking for?
Sir, any spontaneous bacterial peritonitis.
Which bacteria gives rise to spontaneous bacterial peritonitis?
Pneumococcal. E. coli and pneumococcal are most common.
Not splenic abscess or splenic infarct?
Yes, sir. Splenic abscess.
Splenic infarct will give you guarding and rigidity.
Okay. Now, in palpation, you should also mention when you have mentioned the pains on the upper abdomen, you should over here also mention about the Harvey's sign. What is the direction of the flow of the veins over here rather than putting it in inspection.
I think he has taken one video. Show us that
Come
video.
on, okay, go ahead, please.
Yes.
Yes, ma'am.
Show the video of showing the direction of the blood flow.
I think it's all right. We can stick to that, the slide.
It will take a lot of time.
It will take a lot of time. Yeah, please
okay.
go on to
It's
the
okay.
signal. It's all right.
Bring back that local finding.
Yeah, please build back local finding.
Yeah.
Oh, I've lost it. Are you sharing the screen right now?
No, I think
No.
I think he stopped sharing. That's
Yes, yeah, he'll do again. Share the slide again.
Yes, sir.
Yes, I think continue because you see it's because we have now come to the discussion because that's another.
Yeah, that is more important.
That is very important. That is very important.
1 hour is over. So,
sir, I wanted to ask one question in palpation actually. There were visible veins. Have you seen the direction of the flow?
that is what exactly I asked.
Sir, he has seen and he has shown.
Okay, sorry, I was not there. Fine.
Yeah, I would just like to mention one thing that
Yes,
you have mentioned that the liver span, it's like from the fifth intercostal space till the right subcostal margin. So in the liver span, you should actually measure and mention the in centimeters what is the liver span, not just from the subcostal space to the right subcostal margin.
Absolutely, that is the right way, madam. I think totally agree with that. Liver span is measured in centimeters. What is the normal liver span? And there is nothing as from here to here. You have to measure it exactly in centimeters and let us know. So what is the liver span? It is very important in this case.
Sir, liver span from in this case, it was 7 centimeter from the fifth intercostal space to the eighth intercostal space.
How did you measure that?
From the on percussion, I will start the percussion from the mid-clavicular line from the second intercostal space, and where the dullness appears, it marks the upper limit of liver, and the lower limit and I will continue percussion, and I will mark the lower limit of dullness.
So you will continue percussion from up down.
Yes, sir. From the second intercostal space downwards.
So you have mentioned that the patient is having ascites.
Yes.
Right, in your percussion. So is it possible to measure liver span in presence of ascites?
If there is a mild ascites and mild to moderate ascites, we can measure, but in gross ascites, we cannot measure.
So how did you come to the measure the lower border of the liver span, lower margin?
By on percussion or in.
So from where do we start to measure the lower margin?
From where the dullness changes to the tympanic node.
Yes, again start sharing the screen.
Please share the screen.
Share the screen again.
So what's your interpretation of this liver span of 7 centimeters? And what is the normal liver span?
Is it visible, sir?
No.
How will you measure clinically mild, moderate, and severe hepatomegaly?
Make it full screen. Yeah, perfect.
Is it okay, sir?
Yeah.
Yes, ma'am.
How will you measure mild, moderate, and severe hepatomegaly clinically?
Sir, if there is liver, there is a hepatomegaly or there is a shrunken liver due to secondary cirrhosis.
No, I'm not asking about the cause. I'm asking how you measure just in your palpation.
Sir, on palpation, if liver is not palpable normally, it is normal in size. If there is a hepatomegaly, then only we could palpate the liver.
How will you grade mild, moderate, and severe?
Sir, just the grade one is just below the subcostal margin. Grade 2 is up to midway between the umbilicus and midline in the Ziffy's tunnel to umbilicus line, and grade 3 is crossing the midline.
You have to measure
So
with the
that
patient's
is
hand.
that is you are saying with for spleen, not for the liver.
Exactly.
Liver never crosses, I mean, your umbilicus.
Not umbilicus, the imaginary line, ma'am, from the Ziffy's tunnel to umbilicus towards the left.
मैम आप स्पेसिफाई करिए डॉक्टर श्रेया प्लीज स्पेसिफाई ही इज beating around the bush.
Yeah, so actually it's measured on based on the finger measurements, like fingers below the costal margin. So if it's mildly palpable, just palpable, it's a mild hepatomegaly. Less than 2 fingers, it's mild. It's 2 to 4, it's moderate, and more than 2 fingers below the costal margin, it's severe hepatomegaly.
Right, ma'am.
Right. Can we go to the next slide after in palpation?
Sir, have we discussed this horseshoe dullness and shifting dullness? I think.
No, no, no.
बाकी sir.
Okay. So how come both are present?
Sir, horseshoe shaped dullness in percussion, I'll start on percussion from the
No. I am asking you, when you say horseshoe dullness is present and shifting dullness is present, what does it mean?
Sir, moderate ascites.
Moderate ascites. Which sign will be present in mild ascites?
Sir, puddle sign, sir.
No, forget about puddle. I think, sir, you will agree that puddle is not to be discussed.
Finish. Please. Yes,
Unless
please don't
ask you specifically, otherwise it will be difficult. I think.
Absolutely. Please don't mention about puddle sign. Most examiners know.
In mild ascites. So my question actually is that if the horseshoe dullness is present, is it necessary to look for a shifting dullness?
No, sir.
So is it possible to demonstrate that?
It is
possible to demonstrate shifting dullness if patient already has a horseshoe dullness?
No, it is not possible, sir.
Just your idea. So it's okay. They are graded. Why you first check for a shifting dullness in mild ascites? What is principle behind shifting dullness?
Sir, the fluid acclimates in the dependent position, and while checking the shifting dullness, we can on percussion the change in the note from the resonant to dull.
So the principle, Yash, is that there should be a space inside the cavity for shifting of the fluid. What happens if there is a horseshoe shaped dullness? What does it mean?
So there will be no adequate space for the fluid to gravitate on the opposite side.
Okay. So this is a very common mistake. Have you really done shifting dullness in these patients? That's what the examiner is going to ask you, that question. And you will have to demonstrate. So be careful before writing it down or speaking it up. Did you really do shifting dullness? Let me ask you. So it's okay, doesn't matter. The point here is that be careful what you speak. So it should be a horseshoe dullness is present. Why there is a horseshoe shaped dullness in moderate ascites? Very simple question, undergraduate.
Sir, the fluid will acclimate in dependent position like in Morrison's pouch and the paracolic gutters more. So there will be dullness over the flank and the lateral aspect, and there will be tympanic note over the epigastric and around the umbilicus.
No. That is not an answer. Why there is a horseshoe dullness? The point here is that it is the intestine which floats in upper part above umbilicus in a moderate ascites. So that area will be resonant. Rest will be, because the fluid is too much. So rest will be fluid. Only area where that the floating intestine usually gives the resonant knot. That is the reason for horseshoe dullness. It is everywhere. Fluid is everywhere, not Morrison, everywhere. Fluid is everywhere. That is right. Okay. please
like to say, just in the gross ascites, you get the fluid thrill. In that case, you won't be getting the shifting dullness. In moderate ascites, you can still get the shifting dullness.
But the point is that is it necessary if you say that there is a horseshoe dullness? What is the advantage of saying about shifting dullness?
There is no added advantage of that.
The point is that you should be very clear. Sometimes it may not be possible to demonstrate. So if you have not done it, don't write down. That's the point I wanted to clear. Please continue, sir. So what about auscultation?
Sir, on auscultation, normal bowel sound present without any audible venous hum over the dilated veins.
So where did you auscultate?
Sir, in the right iliac fossa.
For peristalsis, anything else?
So for murmur specifically, but due to cross ascites and venous hum was not audible.
What did you say? Sorry, I didn't get it.
Sir, in auscultation in the bowel sound, apart from the bowel sound, I will auscultate for the respiratory system.
No, respiratory is fine in abdomen. So is there any sign which is described in the book? Why I am speaking this? It is very rarely possible to hear it. What is that? Just to complete the discussion.
Murmur over the venous.
Because I was not going to, but you have written no audible venous hum over the dilated vein. Will you get on this superficial dilated vein venous hum? Where do you get venous hum in? Because you have written it. It's very difficult. I have not heard it written. Shreya, can you enlighten on that?
Absolutely not, sir. It is venous hum is heard in a specific place. And where is that? That is what Sir Pankaj Modi is asking you. And you will, such a small vein, you will never hear hum over a vein.
It's the curvilinear compartment hum you heard over the umbilicus.
That is actually very dilated with a lot of collateral. In epigastric, the deep veins can give occasionally venous hum. That's I'm not very sure about it. Please, Shreya or sir, you can say.
It's also very rare, sir, to see such cases. But that's the sign which is described, like for the curvilinear Baumgarten syndrome. It's a dilated venous.
It is better again, like shifting, not to be written or spoken, and not in superficial vein. Keep that thing in mind. It is not. Please continue.
Right. Next.
Case summary. 47-year-old.
The back and spine normal.
Yes, sir.
In MS exam, it is not paradigm. You should always add to your examination that back and spine is normal. Examination of the back, it is abdomen is not over. Okay.
Yes, what sir is trying to say is that conventionally we talk about abdomen examination in 4 steps: inspection, palpation, percussion, and auscultation. Please add 2 more things to your armamentarium: back and spine, and digital rectal examination and pervaginal examination. Okay, so that completes your examination. Please proceed with the diagnosis.
47-year-old non-alcoholic, non-female with moderate splenomegaly with moderate ascites, present with the history of and painless profuse hematemesis. The past history of times. My provisional diagnosis is acute variceal bleed due to portal hypertension.
That is your clinical diagnosis.
Hepatic cause. Hepatic.
Yes, see, whenever you talk about provisional clinical diagnosis, always say the age of the patient, 47-year-old lady with a decompensated portal hypertension. That is more comprehensive term rather than talking about only one manifestation of a decompensation, like variceal bleed, ascites, etc. Okay, so this is the first one to begin with. and you can talk to your examiner if you are not very sure about portal hypertension, that I have a patient with an acute upper GI bleed, in which I will like to discuss the differential diagnosis. So this is the way.
Yes, sir.
So now to please tell me, why did you think this lady is suffering from portal hypertension? A very simple question.
Sir, patient is having splenomegaly, painless, diffuse hematemesis for the first time with the moderate ascites.
Okay, so definitely, so please again, please modify your answer a little bit and say that sir, this is a clinical diagnosis in which there is a splenomegaly with a history of an upper GI bleed and ascites, which with first I will like to confirm my diagnosis with investigation. So that examination open to more discussion.
And also in the case summary, you should mention that there is no history of jaundice and altered sensorium, which is very important in coming to the differential diagnosis.
And as madam has very case summary, Dr. Yash, I think you should have elaborated more important.
Also important negative is positive findings and positive findings from summary, I mean from the history examination, as well as the important negative findings should be mentioned over here. And also you can mention about the past history of a vessel band ligation or an endoscopy with varicose band ligation. So these are points which will help in coming to reaching your provisional diagnosis.
Okay. So I think that yes, after these points are done, as you have said about portal hypertension, what do you mean by portal hypertension?
Sir, portal hypertension is due to increased pressure on the portal venous system. Sir.
Okay, now see again.
Is that the right answer? How do you define portal hypertension?
Sir, the portal venous pressure more than 8 mmHg is defined as portal hypertension, and modified definition is hepatic venous pressure gradient and mmHg.
What did you mention as HVPG? What did you mention in HVPG?
Hepatic venous pressure gradient, ma'am.
Yeah, so what do you mean by that?
Sorry, ma'am, it's a pressure difference between the wage hepatic pressure and the free hepatic pressure measured by the.
So what do you think it will be in case of an portal vein, extrahepatic portal vein obstruction? Will it be normal? Will it be elevated? HVPG?
Yes, ma'am. It will be elevated in portal hypertension.
No.
Not all cases of
Not always. Not always. That is what ma'am is wanting to know, because in your now again at MS level, you have got portal hypertension as your diagnosis, right? Now there are many causes of portal hypertension. What cause do you think is applicable for this patient?
The prehepatic cause.
What exactly? What the diagnosis would be from your history and examination? You have done a full examination and history. What would be the cause, do you think, for this lady with portal hypertension?
Portal venous thrombosis leading to portal hypertension.
Portal venous thrombosis.
Thrombosis.
That is an acute condition. For this,
sir, in this patient, sir, there was sir history of partial portal venous thrombosis when patient.
So that is, I mean, you cannot come to that based on, you don't have the ultrasound findings. So patient is not going to tell you that patient, she is having partial venous thrombosis.
Yes.
What is indicated? I have seen the case papers.
Ma'am,
clinically, what do you think would be your diagnosis? What would be your first diagnosis for the cause of portal hypertension in this patient?
The prehepatic cause, the most.
No, Sim, tell me the condition. So prehepatic, there could be many causes.
Sir, extrahepatic portal venous obstruction is more likely in this patient rather than NCPF.
So you have a choice between an extrahepatic portal vein obstruction or a NCPF, right? Clinically, what would you keep?
So clinically looking at the ascites.
Yeah, I don't know the history. I don't know the ultrasound finding. Clinically, what would you keep as your first diagnosis for the cause of portal hypertension?
Sir, with moderate splenomegaly and ascites, I will keep extrahepatic portal venous obstruction over NCPF.
First would
See
be the NCPF.
Exactly. I would put first as NCPF because the age does not fit into the extrahepatic portal vein obstruction. It is only in the first, and Madam rightly said, first and the second decades of life. So clinically, if you say, see, whatever investigation comes out later on, it's all right. But for clinically, I would keep cause of portal hypertension as an NCPF in this patient. Now, coming to NCPF and coming to the previous question of portal vein wedge pressure gradient, would it be high in a NCPF?
Sir, yes, it can be high, sir.
What is the position of the obstruction in a NCPF? The pre-sinusoidal or post-sinusoidal?
Sir, pre-sinusoidal, second or third order portal venous branches.
So in the pre-sinusoidal cases, you generally get a normal HVPG.
Exactly. That is what I was driving at.
So when you define portal hypertension, it's the actual pressure in the portal vein, which is more than 5 mm. You define it as a portal hypertension. In the cirrhotic cases, you get in the sinusoidal cases and post-sinusoidal, you get an elevated HVPG. So while mentioning an elevated HVPG, it indicates you are having a sinusoidal case of a portal hypertension.
You should realize that this is a pre-sinusoidal obstruction. The hepatic pressure gradient will not be high, right? Okay. Now, shall we discuss?
Are you favoring also the pre-sinusoidal? I mean, it can be patient may be having a cirrhotic which she has decompensated. So what are the? I mean, won't you like to keep a diagnosis of cirrhosis in this case? You have mentioned liver span of 7 centimeters. That too also in the shrunk liver.
Yes,
so, madam is wanting to ask you, what would be the things against a diagnosis of a cirrhosis leading to portal hypertension in this case, as opposed to a NCPF leading to portal hypertension? You have to tell us that.
So no history of jaundice and multiple blood transfusion. All the deliveries of her institutional deliveries, and no high risk behaviors.
That is not a very good.
Think so. So what is the important point in your history which says that patient is not likely to have a cirrhosis?
No history of previous jaundice and fever, fever with chills and multiple transfusion, which goes in favor with the.
There is not necessary that multiple transfusions always favor cirrhosis. So it can occur in NCPF also. Patient can have recurrent bleed. So what is the main finding? Like, what are the important things in your history which suggest that patient might not have cirrhosis?
Ascites, previous long-standing history of ascites would go in favor of cirrhosis.
Would go in favor of?
Cirrhosis, more likely.
All right. So she is not having a long-standing history of cirrhosis. I mean, ascites. What else?
Altered the encephalopathy, history of previous encephalopathy.
Okay, so she didn't develop encephalopathy in this case, so that may favor that she has a more of preserved liver function. What else?
Absence of stigmata of chronic liver diseases.
Okay.
Yes.
So having such a long history, 11 years history of palpable spleen with multiple episodes of other decompensation in the form of ascites, having encephalopathy, no jaundice. These are the things which favor that patient has a relatively preserved liver function, right? So that are the things which are against, which would make cirrhosis differential diagnosis in the lower order. So the first possibility would be an NCPF. So such a long history of bleed won't be available in case of the cirrhosis because they tend to decompensate within the few years, and after bleed the survival is also limited of 3 to 5 years in case of cirrhosis.
Right. So what are you going to now to let us go to the management? What are you? This is acute. Shall we discuss the acute management, or do you think we should? I'm asking the examiners. What would you like to?
Sir, both the things, acute as well as
Okay,
chronic,
fine,
basically
fine.
because the
Okay.
patient has come to us with hematemesis.
Yes. So now what
Dr.
are you going to do?
Khiria, and take from your side, Lakshman.
Yes, sir. Yes, sir.
Okay, fine.
I'm hearing carefully, and it's a nice discussion. What the question was, what is the point in favor of pre-hepatic or extrahepatic portal hypertension? So well compensated episodes of bleed, longer history, and this big spleen favors EHPO, extrahepatic, and NCPF. So just to summarize, 3-4 points that favors extrahepatic, because in cirrhotic patients, they are generally decompensated patients. Ascites is more. Episodes of bleeds lead to decompensation, and splenomegaly is relatively mild or smaller, not the big spleen. If it is a big spleen, always think about extrahepatic or the pre-sinusoidal. It's straightforward, nothing much.
Right. So this patient has come with a bleed. Now, what are you going to do?
Sir,
you are the agency surgical officer, resident on call. My patient with a massive bleed. What are you going to do?
Sir, I will first check the assess the patient, check the airway, and secure the airway if not patient is drowsy. Then check the circulation. I will insert the 2 large bore IV cannulas and start resuscitation with prophylactic antibiotic and some other medications to combat the episode of hematemesis.
You have to put the large bore needle. If you're not taking out blood for investigation from grouping and cross matching.
Yes, sir. I will send blood investigation also, sir, for the assess the severity of bleeding and for the transfusion purpose for the cross matching and to check the function of liver and coagulation profile and the protein albumin, sir.
Right. So, okay. So you would first resuscitate this patient. Now you have resuscitated this patient adequately, right? What now are you going to do next?
Sir, I will give the certain drugs like talibrasin for the high suspicion of esophageal variceal bleeding, and I will after the stabilization of patient, I will go for the UGI scopy to assess the whether the bleeding is active and the grading of varices and for the definitive intervention.
Right. You do find on endoscopy that there is a large bleeder in the gastric fundus.
Yes, sir.
What would you do as an endoscopist?
So glue injection, I will prefer glue injections.
To stabilize the patient, what are the drugs that are used?
Sir, the crystalloids, the antibiotic, the talibrasin.
How does talibrasin work?
Sir, it causes splanchnic vasoconstriction and prevent the bleeding from the GE junction.
What are the other drugs that have been used historically? I agree, talibrasin is the now drug of choice. What are the early other drugs that you use to decrease splanchnic circulation?
Vasopressin and somatostatin analog like octreotide.
What was the disadvantage of using those?
The vasopressin causes vasoconstriction in other smooth muscle also like cardiac muscle and intestinal muscles, smooth muscles. So it can cause myocardial perfusion mismatch and the ischemia in the bowels. Decrease intestinal perfusion.
Right. Endoscopically, how are you going to classify these varices?
Sir,
Do you
endoscopy.
know of any classifications of varices?
Yes, sir. It can be classified whether the isolated esophageal varices or the esophageal gastric varices, and or the isolated gastric varices. In varices, it is classified if it is straight column of varices in esophagus, that is grade 1. A tortuous varices occluding less than 1/3 of the esophageal lumen, that is grade 2, and occupying more than 1/3 of lumen is grade 3, sir.
Any scientists in India or surgeons in India or gastroenterologists in India after whom these classifications are named?
Sir, starts from SI.
Know them. They are legends in their field today, and the gastroenterologist here would vouch for that.
I forget.
Okay, fine. It's Dr. Sareen. Sareen's classification.
Sareen.
Right.
What is the name of that classification you did just now?
Sareen classification.
Okay.
Now coming to, if suppose the gastric varices, you get the endoscopist, you have gone to the endoscopist, and Shreya is a gastroenterologist, and she said that I am not able to control this bleeding, and it have punctured it and it is bleeding profusely. What are you going to do now?
Sir, I will.
You are working. Yeah. Okay, fine.
Sir, I will prefer the insertion of Sangstein Blackmore tube for the temporary control of bleed with intubation and resuscitation, and check ureoscopy after 24 hours.
All patients would need the Sangstein Blackmore tube, even if
No,
you are
sir.
working in BJ Medical College?
No, sir.
No. It is not available in BJ Medical College.
Yes.
Very
So
difficult.
when,
Even
what are the indications of using a Sangstein Blackmore tube or the Minnesota tube?
In the from, if we are referring the patient from periphery where there is no availability of endoscopic intervention and there is a bleeding which is not controlled by the medical management. So for the transport, for the temporary measure, we can use.
Yes. Nowadays it is only used for a temporary measure to transfer the patient to a higher center, isn't it? So that is the only. How long can you keep a Sangstein tube for, and where are the how much of pressure do you put in the Sangstein tube, and for how long can you keep it?
Sir, Sangstein Blackmore tube, the esophageal and the gastric balloons. Sir, the gastric balloon is inflated initially with 50 ml with up to the 250 ml of air. And
of air?
Yes, sir.
Air or saline?
No, sir. No saline, sir. Air.
Okay. And the esophageal?
Esophageal up to 40 mm Hg pressure, sir.
And how long can you keep it for?
Sir, up to 24 hours, sir.
24 hours? It's a long time.
Esophageal balloon, is it water or air? Esophageal balloon.
Air, sir. Both air.
No, it's saline for the gastric. This thing. You inject saline for that for 250 ml. That's saline injection. And the time that you can keep it is not more than 6 to 8 hours. We have never used it, but that's what it seems.
When we were resident, we were using it, and
exactly.
we keep
Long
it for
back.
48 hours. We keep it for 48 hours. Yeah.
What are the complications of it? Complication.
Sorry, sir.
What are the complications of Sangstein Blackmore tube?
Sir, risk of aspiration is the major disadvantage, and the pressure necrosis of esophagus if we are applying too much pressure.
Very good.
Right. So now, suppose you are working in a high-end institute, and the bleeding continues. What will you do?
Sir, I will go for the tips or the tips earlier rather than shunt surgery.
Interventional radiologist is not present. How will you go about it?
Excuse me. Why tips? We are discussing. I think this is extrahepatic or perisinusoidal. So, do you think tips will help in this?
Yes.
For to relieve the portal venous pressure as a temporary measure.
How will it relieve? You are
It
saying
will
this is
not relieve. It is
perisinusoidal.
already obstructing outside. It will
It
not
is
relieve.
beyond the liver. It is just a common sense. What do you think? See, we are mixing two things. One is cirrhotic liver, another is prehepatic, extrahepatic. Right? So
Right now, we are we are discussing it's most likely this is a prehepatic or extrahepatic. So tips is not going to work. So still the patient is bleeding.
Sir,
It's an acute emergency. It's a patient is bleeding. What do you do?
Sir, if endoscopy is available, I will prefer the endoscopic intervention.
But
how many times?
Patient is bleeding.
How many times can you try a endoscopy? But this is a gastric varices anyway, so you can make 2 attempts.
2 attempts, yes.
What's the maximum dose of terlipressin can you give? In what dose generally you use and in start, and what maximum dose you can give?
We gave 2 mg bolus. After that, every for the first 48 hours, we can repeat every 4 to 6 hours 2 mg. Still the bleeding stops for the initial 48 hours, and after that, if when the bleeding stops, we should continue 1 mg in 100 cc NS for 4 to 6 or for the 3 to 5 days.
So minimum dose is your 4 to 6 milligram, and maximum dose is how much?
Maximum 12
milligram. So what are the options available for the gastric varix, which is not like being controlled with the endoscopic management? TIPS is out of question because it's a prehepatic cause.
Shunt surgery. We can perform shunt surgery.
Would you do a shunt? What shunt would you do, and what are the other options that you have? Everybody is not like trained for maybe a shunt surgery, emergency shunt surgery. Any other option that you have?
Devascularization, sir. We can go.
What are the devascularization surgeries that you know of?
Sir, the for HASAB surgery and the Shugira, and the previous ones, Kryle's method, in which there is transaction.
What is Segura's devascularization? What does it improve? What are the?
Sir, it is done in the 2 stage via transthoracic and the abdominal route. We do devascularization of a esophageal varices and the proximal stomach with splenectomy, and we divide the vagus with pyloroplasty.
So devascularization starting from where in the esophagus?
Sir, inferior pulmonary ligament, sir.
From the inferior pulmonary veins, starts from there right down into the
third.
What is Mathur's modification of Segura's?
So only anterior. We take sutures.
Mathur is a surgeon, a contemporary surgeon, and a very famous surgeon, and also an ASI member from Mumbai KM Hospital, Mumbai, and he's got a lot of work on portal hypertension. You should know your bosses in portal hypertension in the country when you're presenting a case of portal hypertension. Yes. So what is SK Mathur's modification of Segura's?
Sir, only anterior wall of esophagus is transected with the suturing over the anterior wall and posterior wall. Anterior wall only.
No, you have to be more complete in your answer. See, you have read portal hypertension. You should be knowing all this. So what are the components of Mathur's modification of Segura's? And Dr. Mathur was one of the examiners a couple of years back also. He would surely be asking you this question if he comes as the examiner.
Sir,
It is basically, it's an abdominal surgery. It's the devascularization of the lesser curvature of the stomach and the gastric vessels. It is transhiatal devascularization of the esophagus for about 8 to 10 centimeters. It is stapling of the esophagogastric junction, and he has not done a pyloroplasty. He just does a
Highly selective.
Pyloanotomy.
pylor, exactly. He opens up the pylorus. So that is that.
Yash, can you tell me, can you only do a stenectomy for a prehepatic cause of a portal hypertension, for a treatment of a portal hypertension?
Sorry, if it is isolated left-sided portal hypertension, then only splenectomy will suffice.
Okay. Now, as we are now telling about prehepatic and hepatic, what are the imaging investigations that tells you whether it is a prehepatic or a posthepatic?
So starting from the ultrasound, ultrasound will tell the status of liver, the size of liver, the echo texture, and any focal lesion nodularity, the status of spleen, whether it's there is a size of spleen, focal lesion within, and the status of portal vein, splenic vein, and supramesenteric vein with dilatation or any thrombosis and collateral.
What is the most important entity that is used in ultrasound in this patient with portal hypertension?
Doppler.
We have seen the anatomy. Any more physiology that you want to see?
Sir, the flow of
if I add a Doppler to your investigation, does a Doppler help in this patient?
Sir, for the status of venous system, the dilatation, how
What
much is
kind
the
of
dilatation?
Doppler will you like to add, sir? What kind of Doppler will you like to add? Will it be a Doppler only, or will it be a duplex ultrasound? Your radiologist is asking you.
Duplex.
What will you like to add in?
Duplex
No, sir. That is the difference between a varicose vein and this patient. In a varicose vein, remember, you add in duplex. That is both an anatomy and a physiology. You need the anatomy of the vein and the flow direction. In a portal hypertension, it is very difficult for the radiologist to show you the portal vein behind the pancreas, but he can tell you the direction of the flow. Now, in a normal patient, in a normal human being, the direction is towards the liver. In a portal hypertension, the direction can be either towards the liver or away from the liver. Okay. Now tell me, doctor, in a patient with a prehepatic cause, what is the direction of the flow in the portal vein?
So direction would be towards the liver, sir.
Okay. So that is called as hepatopetal flow. Whereas in a case of cirrhosis, you will have it opposite, called as a hepatofugal. Now you need other investigations which are going to show, particularly in a case of prehepatic causes, about multiple varices and collateral channels in extrahepatic portal vein obstruction around the portal vein and its thrombosis. Can you tell me that imaging that is going to show you the venous collaterals, particularly around the bile duct?
Such we can go for the CT and splenoportography, which is invasive, not used currently.
No, splenoportography is not done, sir. It is a CT photovenography or an MR venography if you have a kidney compromise. So these basically are done because the minute you talk about shunts, the minute you talk about tips, these are done in between your imaging investigations to tell the surgeon and the gastroenterologist that what they are technically dealing with. This should be done mandatorily before you do a shunt, because the surgeon needs a roadmap around which vein to anastomose at this point. Okay, so that's on my answer. Right. So other examiners, please.
So is it a routine investigations here? I would like to ask you that CT or MR photogram. Should it be in all cases or cases where we are planning shunt or CT?
Yes, sir. For prior to planning a shunt surgery, you should get a CT or an MR photovenogram. particularly to plan with shunt surgery, whether PSRS or SMV to.
Right. The anatomy should be seen.
Anatomy should be seen. Yeah.
Right.
Good.
I would like to mention, have you heard of a procedure named BRTO?
Yes, ma'am. Balloon occluded retrovenous occlusion. It is done in gastric varices, in case of gastric varices.
So yeah, even if you don't have a shunt or the shunt surgery, emergency shunt surgery is not possible, then obviously if you have the option of an IVR, interventional radiology, you can go for large gastric varices which are bleeding, not manageable with endoscopy and your medication. You can obviously go for an BRTO if the anatomy is visible.
Right. Okay, yes, because we are now at the end of the discussion. What are the indications of doing a liver transplant in a patient with a portal hypertension?
Sir,
when do you select liver transplantation as a therapy?
Yes, sir, patient with decompensated liver failure, where medical and the intervention radiology intervention are failed, with Child-Pugh score C, advanced Child-Pugh score, with refractory ascites not manageable by the medical and the tips or the other shunt procedures, and for the patient with cirrhosis, with end-stage liver disease in encephalopathy, refractory hepatopulmonary syndrome.
Right.
Do you correct coagulopathy in patients with acute variceal bleed? What is the role of the, routinely used tranexamic? Is it, tranexamic acid? Do you routinely use or not?
Ma'am, in our setup, we use routinely, but if...
So is it useful?
No proven advantages over the placebo.
Right.
Right.
Correction of coagulopathy?
For the coagulopathy, there is the role of transfusion of platelet if there is a platelet and fresh frozen plasma. If
what is cutoff do you take it?
Sorry, ma'am?
Cutoff for platelet transfusion?
Ma'am, 50,000, less than 50,000 platelet counts with symptoms.
And INR, do you routinely transfuse?
Ma'am, based on solely on based on INR, we don't transfuse.
So what is a restrictive transfusion? Have you heard of the term? Restrictive transfusion.
I'm not aware about that.
So what hemoglobin, particularly in the patient with an acute GI bleed, what is the target hemoglobin to be maintained?
8, around 8.
Yeah, so you do, that is what is meant by the restricted transfusion, that you do not maintain a target of 7 to 8, you do not over transfuse the patient. So what is the side effects of over transfusing?
It can lead to hyperdynamic circulation and secondary cardiopulmonary failure.
So it can increase your portal pressure and it can lead to increased bleed.
Yes, ma'am.
Right. So you have this last, and coming to the end of discussion, I think we've really done. You have this patient of extrahepatic portal vein obstruction, as you said, you have diagnosed it, and there are a lot of collaterals. The portal vein has been replaced by many collaterals, and the liver is well compensated. It is fine. You have a massive splenomegaly. How this patient develops jaundice? What would be the cause of jaundice?
Secondly, to sir, liver failure on top of...
No, there's no liver failure. Liver is absolutely fine. Told you that. I've given you a scenario. Your patient told me. This patient has recovered now. She's had an endoscopy. She's recovered and she's gone home. And she comes back after 2 months with jaundice. What would you think of?
Hemolysis and viral infection.
Sorry?
Hemolytic anemia and...
No.
Viral hepatitis.
In other words, have you heard of portal biliopathy?
Yes, sir. Portal
What is that?
Sir, the changes due to total hypertension around the gallbladder and the common duct, of indentation or pressure stones, can be structure.
These collaterals, when they can compress, put pressure on the extrahepatic biliary apparatus and cause obstruction, right? That is what is called a portal biliopathy. How, suppose now this patient has also wants to get a gallbladder surgery done. Would you do a laparoscopic cholecystectomy? Would you? And I don't mean you. I don't mean your seniors. Would you, as a newly passed out resident, a new surgeon, would you take this patient for a lap chole?
No, sir. Anatomy
Why?
around,
Why not?
sir, the anatomy would be disturbed, and there will be high chance of inadvertent injury due to increased vascularity.
You would never do it. An inexperienced surgeon, a warning for inexperienced surgeon: do not touch this patient. You send it to a senior colleague or to an institute where, because these patients can bleed a lot, and dissection around the calloid triangle is very difficult with these so many collaterals, and often they need to be consented to be having an open cholecystectomy rather than lap chole sometimes. But of course, with expert hands, you can do it, but do not take it as a beginner, these patients. That is a small thing for you, for lesson for everybody. Right.
Right.
Sir, Dr. Pankaj, sir, I have to go for a meeting. Is that all right if I?
Yeah, sir. Thanks for the.
Thank you, Nisha.
Thanks for joining. Yeah. Thank you, sir.
Thank you, everybody.
I will also be leaving, sir, because I have a departmental meeting.
Yeah. No, that is fine, sir. Thank you.
But thank you, sir.
Lakshman, what is your
Lakshman,
what is your take?
Yeah. Till so, I would like to know about hypersplenism. What is hypersplenism?
Sir, clinical laboratory alteration in the blood counts due to increased function of spleen secondary to the splenomegaly.
So, do you have hypersplenism features in this patient?
Yes, sir. Leukocytopenia with thrombocytopenia. So, patient is having HB of 8.8 with platelet counts 33,000 and counts of 3,000.
Okay, so this patient has bleeding, right, which was controlled with endoscopic management and medical management. She is having hypersplenism. So how will you manage further?
Sir, this patient falls in early childbirth score A, sir.
Forget about childbirth. This is extrahepatic, right?
Yes, sir.
So child will not come to this part of the management. CTP scoring is not relevant, particularly for this extrahepatic. So how will you proceed or manage this patient?
Sir, I will prefer the proximal splenorenal shunt, sir. In this
Why? Why?
It will cover the splenectomy parts also, so it will help in the hypersplenism. And say, sir, would benefit in the portal hypertension also. Non-selective kind of shunt, sir.
Can you do selective shunt?
Sir, distal splenorenal shunt is not preferred because, sir, it will only drain the esophageal and gastric, but the gastric part is still there due to gastroepiploic and the some short gastric vessels. So the chances of recurrent of variceal bleeding would be more with the distal splenorenal shunt as compared to the portal splenorenal.
Reversible or irreversible splenomegaly?
Sorry, sir.
Is it reversible or irreversible splenomegaly?
Sir, splenomegaly is, sir, so it can be reversed, but no, it's not reversible, sir.
Why? Who told you?
So I'm not aware of.
Yeah, so it is the raised pressure which is responsible for this stagnation and splenomegaly. So if you divert it, it may regress and hypersplenism may revert back to normal, at least in 50% of the patient with side-to-side shunts. So it is not always necessary that you have to do PSRS or DSRS or side to side, whichever type of shunt you are expert or trained for, you can do that. Yeah. What is the subsequent management?
Sir, I will manage this patient with the secondary prophylaxis for the varices with the beta blocker, non-selective beta.
No. You have done already definitive surgery. Then why secondary prophylaxis?
Okay.
Would you still continue the beta blockers and all that?
Sir, after surgery, sir, check endoscopy would be done at the initially at every month. Then
every month? Why?
Initially for the 6 months, then every 6 months, and after every year.
No. Who does that?
Lakshman,
have you
please
read
elaborate.
that or just assuming?
Lakshman, please elaborate.
No, I'm asking because these are the basic things, how we follow up these patients, because it is not every month, every 3 months, every 6 months. Why? Yes, what we do after surgery, you see the patient's progress, you discharge them and repeat these investigations after 3 months. If there is any abnormality on that, or patient has subsequent problems, as mentioned earlier, that they may develop portal biliopathy because you already disconnected this left part of the portal system from the main system. So the pressure may go up high. So you have to check for the patency of the shunt if you did the shunt surgery.
Yes.
Got the point?
Yes, sir. Yes, sir.
Because shunt blockage is also a common problem after surgery. Up to 30% of the shunts get blocked after surgery.
Yes, sir.
So if your patient is not relieved of her symptoms, except the sphenomegaly part. So you do the after 3 months or 6 months, and that's it. This is how we follow it up. Fine. Yes, sir. Anything else you would like to discuss?
One thing is,
anything about liver transplant? Prashant, do you have anything?
Rectal varices. Yes. What is the difference between rectal varices and piles, and how will you manage bleeding from rectal varices?
Sir, rectal varices are bleeding from the rectal varices are less common, but it can happen, and we can go for the dietary modification initially. If patient is having constipation with high fiber diet and increased fluid intake, if patient is not having severe ascites, and later on after the surgery, it will regress in most cases, sir. So no other specific intervention required for the rectal varices.
Clinically, how will you differentiate between rectal varices and piles?
Sir, the rectal varices would be, sir, at the upper part of the rectum, where at the above the dentate line, and the lower the piles would be, sir, below the dentate line. The dilated, sir, submucosal veins would be visible in varices, sir, in a vertical manner, and in piles there will be the mucosal outpouching with the purple hue would be visible rather than a dilated vein.
Okay, very good.
With liver transplant, this is not a case, but Dr. Shreya, anything remaining?
No, sir. I would like to just ask whether you would give anticoagulation or even antiplatelets after the shunt surgery. Would you like to give, or would you evaluate for anything else after shunt surgery, or if the shunt gets blocked?
Yes, ma'am. After, if there is a blockade of shunt, I will go for the investigation to check the degree of stenosis or the patency, and degree of dilatation retrograde, how much is the dilated, and will manage accordingly.
Regularly give antiplatelet or anticoagulant after shunt surgery.
We should give for the prophylaxis for the initially.
What are the role of statins? Statins and aspirin.
So aspirin is for the anti-platelet. So we should give as a prophylactic measure.
And what you will give? Aspirin and statin, atorvastatin and aspirin.
Sir, statin, the role, I don't know about this role of statin, but we should, if patient is having the associated cardiac conditions or the hyperlipidemia, then we can prefer the giving statins in old age patient.
Prashant and Dr. Khira, please clarify regarding these things. Post-liver transplant.
It is not related to transplant actually. In the cirrhotic patients, portal hypertension has dual mechanism. One is structural architectural modification in the liver. Second is functional component. So the structural architectural component is 75%, which lead to portal hypertension. That is fibrosis, regenerative nodule formation, and that causes sinusoidal pressure. That increases the pressure. Right? And the second component is functional component, that is reduced nitric oxide production inside the liver and increased production into the GIT of nitric oxide. So what statins do, they have antifibrotic activity. They reduces the structural component. This is how they help in the portal hypertension. While nitric oxide component, which is reduced in the liver and increased into the GIT part and systemic circulation, that lead to hyperdynamic circulation. To curtail the hyperdynamic circulation, you give beta blockers, particularly non-selective beta blockers, right? Which act on the heart as well as GIT. Beta 1 act on the heart, that reduce the cardiac output, and beta 2 act on the GIT part, which reduces the splanchnic component, and this reduces the hyperdynamic circulation. This is how medical part of the portal hypertension is tackled.
Right.
Anything else?
Particularly, the simvastatin is used for the functional component, not like all statins are being studied, only the simvastatin, which has been studied for portal hypertension. And another thing nowadays, carvedilol is also being used to along with instead of the propranolol, which is a non-selective beta blocker. Carvedilol is an alpha plus beta blocker. So for the primary prophylaxis also it's being used because alpha blockage also leads to, reduces the portal pressure and also it increases the risk of perfusion.
Right. Jayesh bhai, any inputs?
No, it is a very good discussions. And but one point I want to just add, all the candidates must learn to present the case fluently and without seeing any notes. So that is the only one point. Here it is a, because in exam it is a different scenario. Here he is reading the all his point, but in exam he has to memorize everything. So that is only final input from me.
Right. Okay, then Nina ma'am, shall we leave? Anyway, yeah, anyway, thank you everybody.
Thank you for inviting.
Yes,
thank you everyone.
Thank you. Yes, you did well, and this is a learning experience for everybody. Please, we'll just leave then. Thank you.
Thank you, sir.